There's a revolutionary technique that's changing the way we treat veins. It's called FoamSclerotherapy. It's not widely adopted in the UK, but if you're a doctor, nurse, or indeed any healthcare professional with an interest in veins, you may already know that FoamSclerotherapy can treat any vein, from spider veins to blue veins, from varicose veins to severe vein reflux. It can treat veins on nearly any part of the body, from legs to chest, from arm to hands. And what's more, it can treat veins that have come back after laser, radiofrequency, surgery, or superglue. So, if you treat veins, you really must master FoamSclerotherapy to be able to offer your patients complete vein care. In this video, I chat with a legend in the world of FoamSclerotherapy, Alessandro Frullini. We discuss how I first learned about FoamSclerotherapy from Alessandro nearly 20 years ago, how I was truly amazed what FoamSclerotherapy could do, and how Alessandro inspired me and my colleague Emma Davis to set up the British Association of Sclerotherapists. We'll also find out why a Ferrari is not the best car in the world. Yes, I know it's a bit random, and it's a bit shocking coming from an Italian, and why Alessandro now only uses FoamSclerotherapy to treat veins. Be sure to stay to the end, where Alessandro shares his top tips for successful FoamSclerotherapy. Let's start with a taster of what to expect. I mean, we must have met about 18 years ago when I came to your fantastic sclerotherapy conference in Bologna. And I remember I was completely blown away by the content of your meeting, because at that time I was a vascular surgeon in England, and I thought I was very up to date. I was treating veins with endothermal ablation. And at your meeting, I was introduced for the first time to the fascinating world of FoamSclerotherapy. And I remember you had invited Juan Cabrera to give a presentation where he showed a video of a patient that he had treated with FoamSclerotherapy. And he got the patient to stand up immediately. And because the veins were still in very intense vasospasm, the veins disappeared, and my jaw dropped. And tell me, how are you making your foam now, Alessandro?
That's interesting. Well, usually I use two techniques at this moment.
Now you've had a taster, let's get started. Thank you, Alessandro. I mean, we must have met about 18 years ago when I came to your fantastic sclerotherapy conference in Bologna. And I remember I was completely blown away by the content of your meeting, because at that time I was a vascular surgeon in England, and I thought I was very up to date. I was treating veins with endothermal ablation. And at your meeting, I was introduced for the first time to the fascinating world of FoamSclerotherapy. And I remember you had invited Juan Cabrera to give a presentation where he showed a video of a patient that he had treated with FoamSclerotherapy. And he got the patient to stand up immediately. And because the veins were still in very intense vasospasm, the veins disappeared, and my jaw dropped. And I was with my colleague Emma Davis, and her jaw dropped as well. And we went back to England after your conference, and we thought, we need a conference like that in England to introduce doctors and nurses to FoamSclerotherapy. And we set up, Emma Davis and I were working collaboratively at the time. Emma Davis is a nurse, and she's gone on now to do great things in the cosmetic world. Emma Davis and I decided when we got back to England after your conference in Bologna that we would set up the British Association of Sclerotherapists. And we had our first meeting ever of the British Association of Sclerotherapists in 2005, and we introduced our colleagues to FoamSclerotherapy. We were so inspired by your conference.
Sclerotherapy.
Yes. So,
FoamSclerotherapy.
so tell me, you've been an innovator in foam sclerotherapy for many years. How did you get interested in it, Alessandro?
Well, I started in 1997 with FoamSclerotherapy.
1997,
I've
right.
heard about a presentation by Haroun Gajraj. It was done in Paris a couple of months before. And, well, I was already doing sclerotherapy, echo-guided sclerotherapy. I started in 1994, I think, so 40 years ago. But I was using sodium tetrahydrosulfate. I was using iodinate solution, but the results were quite good, but not so good as I wished. So I've heard about this foam, this new thing. So together with Attilio Cavizzi, we were doing studies together at that time. I started to think about it. And, I was very brave because the first patient I've treated with foam was in 1997. It was a relative of a doctor. So double brave for this.
Yes.
There was old lady with a very big vein on the left side, I remember. And she didn't want to have surgery. She didn't want to have any, at that time, no laser, no radio frequency. The only alternative was sclerotherapy. I tried to make sclerotherapy on this woman a couple of times with the usual solution with no results. And she told me, doctor, I don't know, maybe she had an ulcer also. You have to do something. I don't want to make surgery. And I say, okay, we can try this new thing about foam and so on. So, okay, go on, doctor. I don't care. Do it. Okay, I made the injection, eco guidance. And as usual, I made the injection. I waited a while. And then I was searching for the vein again. But I was scared because I didn't saw anything. Because I was not used to such a spasm. And didn't know very much about the shadow cone, all concepts that now are normal for everyone who's making this. At the time, it was the very beginning of FoamSclerotherapy. So I start searching with my probe on the thigh. I didn't find anything. I started to swear, okay, what's going on? Then I found below the knee this vein. But all the vein was completely disappeared in the thigh. So I realized that was something very huge that could change the phlebology. And
yes.
This is what happened.
Yes. But tell me, I remember when I came to the meeting with in Bologna, my first introduction to your conference, and I saw Juan Cabrera demonstrating this. It was very secretive when it first started. Juan Cabrera had this big vat with whisks and special potions and so forth, and it was very difficult to know what it was. When did you start? Was it after Tessari had demonstrated?
Later. At the very beginning, we all were using the Monfort technique with the
Monfort technique. Yes.
Because the Tessari technique started very, very late. Because for a couple of years, Attilio Cavizzi and I, we published several papers on this topic, but all with the Monfort techniques. I can tell you how it started in Tessari 1. The Tessari technique was in November 99.
November 99.
November 99, I was going to a meeting in Siena, And I found Attilio Cavezzi over there, was waiting for me, and told me, okay, come, I have to show you something. And I met Lorenzo Tessari, who went in the bathroom of the university, and he showed us what he has found, these three-way techniques. So we started from that. It started at the beginning of the year 2000, the Tessari technique.
Right, right. So when I came to your conference, already Tessari was well established.
Yes, yes.
Yes. Okay. Okay. And tell me, how are you making your foam now, Alessandro?
That's interesting. Well, I usually I use two techniques at this moment, mostly with the two-way connectors, like the didactic one, and the varicose.
Yes.
For more severe cases, I use varicose. Well, I use foam mostly for large veins.
Yes.
I don't use foam for telangiectasia, for spider vein. I don't think it's necessary because foam works because it fill up the vein and the contact with the solution, with the foam, with the drug is much longer, and so this is necessary for a large vein. But for small veins, for a spider vein, it's not necessary. In fact, when you inject a spider vein, it blanches.
Yes.
So it means that you fill up with the solution. I have a special technique, I call it long contact one. If you make the injection and you hold the needle inside, or you transfix the skin with and hold over there, you will see that there is no return of flow of blood inside the spider vein for a while. So you can enlarge the time of contact with endothelium. So I don't use it especially, but sometimes maybe for metting I can use foam, but it's very rare for me. For small tributaries, I can use the double way technique. For larger veins, especially when venous vein is more than 1 centimeter, I definitely use varicose, very good results.
Okay, right. So, you know, this is fascinating to learn the history because, I mean, I'm talking now to the people who invented it, who developed it, and it's fascinating for us. Here's the thing, Alessandro. In England, there is not much enthusiasm, I don't think, for foam sclerotherapy. We have a tradition in this country that endothermal is regarded as the best treatment. You probably know this because you've seen the NICE guidelines and you've seen the European guidelines and you've seen the American guidelines. And in all the guidelines, and you talk to my colleagues, they say endothermal is the best. And they say it's the best, particularly if the vein is over a certain size, 6, 7 millimeters. You've just said that if it's over 10 millimeters, a centimeter, you use varicose.
Yeah.
And you get good results.
Absolutely.
Okay.
Well,
so
go ahead.
So stop there because I think that is something that just needs to be thought about for a minute. Foam sclerotherapy will treat large veins, large refluxing segments of saphenous veins very well. So why is there this feeling that endothermal ablation is best?
Well, Haroun, if you would ask me, which is the best car?
Of course, yes.
You can say it's a Ferrari. You can say the best car is a Ferrari. I would say that's the wrong question.
Yes.
You should ask which is the best car for a specific person. Because if I have a large family with 4 children and a big dog,
Yes.
they cannot fit inside the Ferrari. So that's not a good car for me. If I have back pain and the Ferrari is very low, I cannot go inside over there. If you live in Florence, which is a very old city with medieval street where you cannot pass inside because they are very narrow, maybe a Mini is the best car. So the same thing is for veins.
Yes.
The presentation I said you
Yes.
the problem. We just say about vein, greater vein, without specifying what are we talking
Yes.
about. So we are talking about cards, but not considering the single patient, the single vein.
Absolutely. Absolutely. I think you've made that point really well, because it's in a sense, the comparisons are silly. They're not important comparisons. To say in the guidelines, NICE guidelines, European guidelines, American guidelines, that endothermal ablation should be first choice, and then to say second choice is if that's not possible for technical reasons, is absurd.
It's absurd.
It's absurd. It's absurd. It's absurd.
Absolutely.
Okay. So was that the motivation for your new classification system, which I'm going to present later on in the talk? I'm going to show the audience your presentation in its entirety. But was that the motivation for you to try and distinguish, as you put it in the presentation, apples and pears? They're different.
Yes. Well, motivation because I have my background, I'm also a general surgeon. I started as a general surgeon and a vascular surgeon. So I know about the TNM system, all these kind of things.
Yes.
So I know there are stages. I don't understand why we shouldn't have stages of involvement also in pathology. That's right. And also I always thought that CAP is useless. Well,
Yes.
it's something maybe nice, can be all those letters and numbers, but I'm a practical person, and for daily use they cannot use, and there is no true, how you say, it's not reflecting also the hemodynamics, at least some hemodynamics. So this is the aim of this classification is to do something simple that you can do in a few seconds. And it's not, I'm sure, it's not the best way possible. I can also make it much more complex, but you should have a balance between complexity and, what you can do in the daily use in order to make it usable for everyone.
Yes, 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 yes. Okay, so tell me now, firstly, is FoamSclerotherapy your usual practice?
Absolutely.
Do you do any endothermal ablation?
Not anymore. I'm not doing any more Leifos. I'm not doing any more glue. A few years ago, I started for a couple of years. I've made glue occlusion of the saphenous vein. But then when it comes varicose, I stop it because I use glue only for those veins so large, so or when you have failure in the treatment, so I shift to glue. But at this moment, when I started with the varicose, I would say I had no more need for this. I have to confess that I still have 2 kits of glue, costly one, in my office, which expires because I didn't use, because I didn't have the chance to use it.
Okay. And of course, you've never done phlebectomy.
I've done in the past, but not much. No.
Okay.
Well, in 1 year of practice, I usually send no more than 2-3 patients to surgery because they are huge, so huge that I don't find that it's ethical, or because of, let's say, patient-related reasons. Some patients are very difficult to manage. They don't want to use stockings, so they don't want to walk. So when they are too difficult, okay, go and have surgery.
Okay, that's good. Okay. So it seems to me, Alessandro, from what you're saying, is you've progressed from surgery to foam sclerotherapy, and then you've progressed beyond other endothermal ways of treating, glue, laser. You don't do them anymore, and
No.
foam sclerotherapy can treat pretty much all the veins in your clinic that you see. Is that a fair comment? Yes.
Yes, I would say yes. I know that some people it's obsessed by the so-called recurrences. But again, please tell me. I always talk with my patient very frankly, and say, okay, you have this kind of vein, you have to make treatment. What I think it's good for you is the FoamSclerotherapy. There are some other treatment, maybe endothermal, maybe surgery, what you want. Probably in the next 10 years, if let's say we have a good result, okay, the vein is closed. In the next 10 years, probably we have to make 2 more injections to keep the results. Probably will be 0, probably there will be 4, I don't know, we don't know. But if you make surgery or if you make endothermal, probably you have to make only 1 or 2 instead of 2 or 3 injections, because this is what happened in reality. Is it a problem for you if we make surgery and we make 1 or 2 more injections in the next 10 years? They say, no, not at all. That's key, I think, to understand why people do prefer FoamSclerotherapy. The term recurrence, I think it's misleading. We have something, a disease which has a progression. It will be like a patient with diabetes who have an hypoglycemia or an hyperglycemia. Can you say have a recurrence of diabetes? No, it's a lack of control. This is what we are aiming, the control of the disease, not the eradication of the disease.
That's wonderful. I'm going to quote that because I think that is the essence of the treatment of venous disease, Alessandro. You put it so well. I'm going to steal that quotation. Tell me, what was the highlight of your conference for you? I know your conference has been going for a long time, and you have also now presentations on endothermal ablation and other types of treatment. How do you think foam sclerotherapy fits in with all these other treatments?
Well, I think it fits very well inside, because the name was sclerotherapy meeting in the past. Then some years ago, I changed it in sclerotherapy and venous ablation, because we have to be open-minded. We cannot say, okay, just sclerotherapy. But year after year, we see that the sclerotherapy is more and more present. This year, we had Haroun Gajraj who presented his new device for foaming, and some other new devices have been presented. Some catheters. There is a nice device with a clip. Is an external a clip you can put with a needle inside, outside of the vein, to close it in order to help sclerotherapy. We had a lot of new things presented at the meeting. We were more than 800 people, so we are very happy about this meeting. We have people from all around the world. So hope to see you the next edition
Next
in 2000.
next year. I hope next year. Do you know, I learned so much from those conferences, and it has not taken off in the same way in England, in the UK. I think foam sclerotherapy is regarded as a little bit fringe. And I was talking to the current president of the Venus Forum here in the United Kingdom, Professor Bruce Campbell. I don't know if you know him or you've met him, but he is of the opinion that, well, he has concerns still in 2024 that foam is entering the deep veins and how can he stop it, and the bubbles going to the brain. And these are things that have been resolved and talked about and are no longer an issue now at meetings. I remember you were one of the people that first helped us understand how these neurological events might happen. And I think still in this country, some people are worried about bubbles going to the brain or going into the deep system. But you were one of the first. Were you the first person, Alessandro, to talk about the term endothelin? Or
yeah, I think we made the first studies on the endothelin. We made it on in animal model, on UVEC, and in patient, and we proved that endothelin, which is a very strong vasospasm agent, is released by the area subjected to sclerotherapy. And also, there is some understanding why in patients with a patent PFO are more subject to this kind of problem, because endothelin-rich blood goes to the right heart after sclerotherapy, and then there is a scavenger effect or something like this, because it bonds to the ATA receptor in the lung. So
right,
the blood on the left side should be always with less endothelin. If you have a shunt, you can have a endothelin-rich blood going to the left heart, and this is one of the reasons. We used initially aminophthone, which is a drug which I don't think is present in the United Kingdom.
no.
We made a study, it's a percomet study, with a multi-center study, where we were able to demonstrate in a large number of sessions that, especially for spider veins, we had a significant reduction of the side effects, and especially for migraine patients. Migraine patients are subject to have more frequently some side effects. So with the prophylaxis with aminophthone, we were able to reduce by 10 times the side effects in migraine patients. So I think this could be at least one of the reasons of this kind of effect. But let me go back to what you say about the fear for complication. But everything in medicine could have some problems. Even surgery. I sometimes present a slide of a British newspaper some years ago. The title of the journalist was, well, varicose vein surgery cost me a leg. Because in that, it was, a little hospital somewhere in England where there was some problem where maybe they stripped the artery. I don't know.
Yeah.
And that have a reputation. We have also in Florence about 15 years ago, experienced surgeon who stripped the femoral artery instead of the spinal cord. So we cannot say there is a safe procedure without any drawbacks. No, not at all.
Yes.
But at this moment, FoamSclerotherapy is probably the most used treatment in the world for venous insufficiency, because it is used for spider vein, tributaries, the venous vein. Everybody in the world is using it so much. I remember that there was a study some years ago it was in 2013 in USA, made by a Canadian company who made a study on what was done from 1999 to 2013 in US. And you can see that surgery dropped down to 1%, but the most frequent treatment for gallstone vein was not endothermal, was not glue at that time, but was FoamSclerotherapy. Was sclerotherapy, not FoamSclerotherapy. So we saw a huge number of FoamSclerotherapy made every day in the world. If it would be so dangerous, you will have a lot of publication about this.
Yes, well said, well said. So I'm going to show your presentation now, and then afterwards you can tell me what you think the significance of your findings are, and what we should be doing about it. So,
the Boudier classification of saphenous insufficiency. Is ultrasound-guided sclerotherapy comparable to thermal ablation? Trials, guidelines says no. Thermal ablation is superior to sclerotherapy. But I think we have forgotten something. This is a rhetoric question. Can we compare apple and pears? Obviously not. But we are currently comparing the results of different veins treatments without considering that sometimes we have apples and sometimes we have pears. And guidelines do not consider the differences. Look at this. All these are great saphenous vein, C3 probably, and are very, very different each other. And even regulatory agencies also prescribe the same treatment, the same sclerotherapy, regardless of the specificity of each patient. And the only method of standardization is CIAP, but the same CIAP, the same C can be associated to very different veins, and the clinical status is not related to the anatomy and hemodynamics. If you look at these two legs, C3, great saphenous vein insufficiency, but as you can understand easily, they are very, very different, and you cannot state that the same treatment could be fine for the right or the left one. And also, to predict the outcome of the treatment, CIAP is useless. This would be like comparing aortic aneurysm repair techniques on the basis of the appearance of the abdomen. It's obvious it is not the right way to do this. Standardization is not about using the same concentration or volume. In meeting congresses, you always listen to somebody who wants to standardize the treatment using the same polydocanol 3%, the same syringe, and so on, but it is not, or at least the standardization is not just that. To standardize, we must start from the beginning and compare similar veins. And therefore, we need objective tools to state similar vein. The difference between veins can be found at different levels: hemodynamic, patient-related, and on the anatomy. And sclerosing treatment on the GSV, for instance, where only the preterminal valve is incompetent, is very different from the one where you have a double incompetence of the terminal and preterminal valve. Look at these. In case A and in case C, you have quite common situation. In A, you have both valves which are incompetent, and C, only the preterminal valve. The results of sclerotherapy on these two different veins are very different. Difference related to the patient, to the anatomy, as we said before, and also for the length of the incompetent vein is a parameter that is not usually taken in account. Previous treatment, to get a good result, you need a good intima if you want to make sclerotherapy, and diameter distribution. If you look at this, you can see that the length of the insufficiency can be very different. And you cannot say where only a very short segment of the saphenous vein is incompetent is the same condition, or where all the vein is incompetent. Going to venous diameter, the most misunderstood variable of phlebology. And a single measurement is not representative at all. And there is not always a relationship between the clinical picture and the diameter of the vein. You can see here, you can have a quite large vein with a large varicose vein, but again, you can have a larger vein without many varicose veins, or even here, and even here where you have a larger vein and no varicose veins. We need a tool to improve the definition of the vein in the specific patient. This method I developed, the DIF and VDL system, is quick and easy to calculate. We have done a study at 30 seconds. It's enough, more than enough to classify the leg or the vein. Its objective is based only on objective data, standardized, and have as anatomical and hemodynamical data together. It's made with a duplex in a standing patient. Measurement must be done without pressing with the probe. You will have NTPD is according to the competence of the terminal valve. Measurement of the largest segment in 4 positions, saphenous arc, upper third, middle third, and lower third of the time. Look at this. For instance, you have the first letter is DO, is double, means double incompetence of the terminal and preterminal valve, and the diameters in these 4 positions. The largest one is 13.5 at the arch here. On this side, on this patient, you can have similar veins, or at least similar legs, but the veins inside are very different. On one side, you have a preterminal valve incompetence only with quite small diameters. On the left side, you have a double incompetence. You can see with a very severe insufficiency at the groin and large diameters. So DIF is used to calculate the VDL, which is the true classification. V is for valid status, D for diameter class, and length, L for length of incompetence. So from the DIF, you can get the VDL classification. In this example, for instance, you have DO, which is the valve status, class 3. It's a diameter between 8 and 12, and 4 means the length of the incompetence vein gets to the upper third of the leg. So you can see here how we classify the valve status, and for normal, P for the preterminal valve only incompetence, T for incompetence of the terminal, isolated terminal valve incompetence, and DO is for double incompetence of both valves. And the diameter classes 1, 2, 3, 4. We only pick we only take the largest segment at all, and in one of these classes. In the length of incompetence, you see 6 areas from the groin to the ankle. We already published this classification. Some example here, you can see a quite large arch with more than 10 millimeters of diameter, and one, so the double incompetence, 3 means the class of diameter is the 3rd class, and 1 means that only the upper third of the thigh is affected by incompetence. In this leg, on contrary, you have a very large arch. It's a venous aneurysm with 18 millimeters, so double incompetence and a little longer incompetence of the vein. Again, here you have a P, means that you have only a preterminal valve incompetence, and a much smaller diameter, and the length of the insufficiency gets to the lower third of the thigh. Can you see here? Yeah, these two veins are very different. So you saw before, when the only preterminal valve incompetence is present, usually diameter are much lower. On the other side, you have a double incompetence with larger diameters. Here is the example of a preterminal valve incompetence. It's probably a anterior saphenous vein insufficiency. And here it's a normal junction, but you have a perforator in the thigh. So all of this is made to, in order to try to predict the outcome. So you can create a grid like this when you can stratify the severity of the disease of the great saphenous vein. And obviously, on the left side, where you have milder cases, the results of sclerotherapy are probably much better than in case like DO4, when you have the largest vein with the most severe insufficiency, where maybe thermal ablation would be more advisable than other kind of treatment. But at least you can start to stratify risk. We have done a multi-center study with the Italian Phlebology Association on more than 1,000 insufficient great saphenous vein, also ranked by side, because this is a very interesting thing, but something that we didn't expect, but we have found something very interesting. We didn't study the L factor, the length of the incompetence at this stage. This is the distribution of the disease in different classes. And we go and see what happened on the right, on the left side, we found some differences. And but only when preterminal and terminal valve incompetence were present. When only preterminal valve incompetence was present, there was no difference between right and left side. And also the distribution diameter was same from the left to the right side when only the preterminal valve incompetence was present. Things start to change when we have both valves who are incompetent. Maybe this could be an argument in favor of the center interior or the venous insufficiency, I don't know, but it's a clue. If we, you see the aggregation of the results, and as we can expect, when both valves are incompetent, the diameter are much larger, so the veins are more diseased. But when incompetence of both valves is present, the distribution of diameter from right to left side differs substantially. And we found that the right great saphenous vein is different from the left one, and it's very different in diameter. And also, on the right side, the largest diameter was significantly present very often on the lower third of the thigh. And this is clear a difference between the right and the left side. On the right side, on the left side, as usual, as we expect, the larger diameter is always at the juncture, but not on the right side. And if you think that some techniques of sclerotherapy um, some, um, have the injection made at the lower third or the upper third of the tide, this could be something significant if you have the largest segment in where you make the injection or not. So in conclusion, there is clearly an interest from companies to push for a technological solution of venous insufficiency. To put together everything is not helpful, and we need something to in a way to better identify which kind of vein are we treating, and to argue that a thermal ablation is superior to sclerosis is like arguing that radical mastectomy is better than a lumpectomy for breast tumor. But we have also T1, T2 tumors. It's necessary to start staging the level of saphenous vein disease. And CEP is not a reliable predictor of the treatment, and we need a better method. I think that the VDL system is something helpful in trying to avoid this, to put apple and pears together and to make a fruit salad like this. So all studies and guidelines that do not consider do not differentiate between right and left have serious bias that could invalidate the conclusions. And a system like this, with a stratification of the grade of involvement of the crystal saphenous vein, I think it should be what we should aim for the next years. And thank you.
What is the takeaway message from that fantastic presentation of your original findings? What is the takeaway?
I think we have to start that the Ferrari is not the best, even if it's Italian, it cannot be the best car in the world. Every vein is different. If we don't start to differentiate in stage, in classes, our veins, our patient, we cannot really make a good job. If we start to do this, we can compare apple and pear. Not, we have to compare apple with apple, and maybe red apple with red apple and green apple.
Yes.
Green apple.
Yes.
Okay?
Yes. I think that is the point, and I think I have to say I hadn't come across that classification. Do you know it was Enrique Roche who said to me that Haroun, Alessandro has a new classification, and it's very simple to understand. And I think you should talk to Alessandro. That's why I contacted you. It was because of Enrique. Now, tell me one last thing, and this is just for comment. You may not want to comment or get hooked into this debate, but I'll ask you this question. In the United Kingdom, we have these nice guidelines. They say several things, but the important things that they say is, among the important things, that all patients with a venous condition should be referred to a vascular surgeon in the United Kingdom. And the second thing they say is that endothermal ablation is the number one choice. Now, I've been thinking about this quite deeply recently, particularly as I've been following the crisis in access to vein treatment in the United Kingdom. We have this terrible situation in the United Kingdom, Alessandro, that people with leg ulcers are waiting for treatment. They wait for their primary care doctors to see them. They wait for their arterial, the ABPIs to be done before they're even started in compression. And then they're referred to a vascular service with vascular surgeons with huge waiting lists. And some of them wait a long time for any intervention. Now, I think these two things, the fact that they have to be referred to a vascular service, and the second thing that they have to be treated with endothermal first, is delaying treatment. Whereas if they could have access to FoamSclerotherapy, perhaps in the community, they would be better served. Do you have any comments, or you'd rather not get involved in that debate?
No, I can comment.
What do you think? What do you think?
I think I would say that nice guidelines probably are not so nice. about this. Yes, the problem is the same. I'm a vascular surgeon too, but vascular surgeon is not a phlebotomist.
No.
There is a huge difference because, I teach phlebology here in Italy for so many years. I've done it. And there are many, many vascular surgeons who have done arterial surgery for all their life. When they go retired, they come to one of our classes, our courses, to learn something about phlebology because they don't know nothing about this. So the problem is that, unfortunately, the phlebologist is something that exists in the clinical, in the daily life, but it's not an academic role. There is not an academic figure of a phlebologist. This is what we should need, because the phlebologist is someone who does a different job and also know sclerotherapy, know FoamSclerotherapy, know how to deal with ulcers, with complex ulcer, and so on and so on. This is why I think we have also some process ongoing in Italy in order to try to convince our government that something should be done. Try to think to what you say about ulcers. We know from studies that if you have a patient with an ulcer, if you treat the reflux, the patient heals quite quickly. But I don't know about your country, but here in Italy, patients with ulcers are referred to districts, to medical, where only nurses take care about this. Usually the doctor is not someone who has some interest in venous ulcer. So everything is done by nurses. Maybe no bandage at all is made most of the times. Sometimes one advanced medication is used, and next week there is another nurses use another one, and so on and so on. And think what if just FoamSclerotherapy would be introduced for this patient, usually old patient. We can have safe, will have better results for patient, closure of healing of the ulcer in a short time, and a huge amount of money saved by the national health system. This is very clear for me, I think very clear for you, and for all the people who know about this. The strange thing is nobody is going to do this.
Well, I think it's partly because it is in the domain of the vascular surgeons, and
that's the problem.
That is the problem. And I think also the other problem is the influence of the big medical device companies on the way that the guidance is incorporated, or how it's.
This is why they will not like my classification.
They won't like your classification, no. And you're going to lose all your sponsors at your meeting, Alessandro.
Okay.
Alessandro, thank you very much for chatting to me. Is there anything else you think we ought to know about the wonderful world of sclerotherapy before I let you go?
Well, I think that the only thing I can say that it changed my world. It changed my practice. I'm very happy to have been involved in sclerotherapy, in FoamSclerotherapy, because I see in my patient what medicine can do. It's easy.
Yes.
Because there are very few things, and also, in my opinion, helps to get a good relation with the patient.
Yes.
We know that, at least in Italy, we have a very bad problem with the patient-to-doctor relationship. In hospital, there's violence. There's a lot of bad things.
Yes.
But FoamSclerotherapy, or at least sclerotherapy, is something you do with your patient. It's not you who's doing the treatment. You do it together. You have to make the injection. He has to walk. He has to his talking. So it's something that is very rewarding, I think. in consideration of the patient-to-doctor relationship.
Okay. One last thing. What is your top tip for getting good results with foam sclerotherapy? Your top tip.
We have to differentiate between apple and pears. It's not so easy, but I think that in my practice, some simple things. First, to inject where is the reflux source. I know that many people injecting well away from the saphenofemoral junction. I think the problem, because if you inject, for instance, at the lower third of the thigh, you will put the most active foam over there where you can have some side effects, and the foam which gets to the junction is somehow contaminated with blood. So where you need the most active foam, you will have the less active one. First of all.
Yes.
Secondly, compression.
Yes.
I think the class 2 compression is mandatory to get good results. And I never use, for instance, microfiber stockings, because the working pressure of that stocking, even if at class 2, I think is not enough. That's all.
Alessandro, thank you very much indeed.
We had fun. I had fun very much. Thank you, Haroun.
Thank you. Alessandro, it's been fantastic to catch up with you. How do you look so young? You look the same as you did 20 years ago.
I don't know.
Is it red wine and sunshine?
No, maybe Italian sunshine. Okay.
Alessandro, thank you very much. I look forward to seeing you perhaps in person next year at your wonderful meeting.
Okay.
All right.
Okay.
Thank you, Alessandro. Thank you for watching, and thank you for staying to the end. Be sure to like and share. It really does help my channel. And why not subscribe? That way you won't miss my next video.